Perfect. So we're so excited to be able to present this topic for you all today. It's titled Grief and Mental Health Among Migrants and Refugees, Challenges in Hispanic and Latino Communities. And we are the Resource and Empowerment Technical Assistance Center for Behavioral Health, also known as RMTAC. And our programming and our project is made possible by funding through SAMHSA, which is the Substance Abuse and Mental Health Services Administration. I will hand this over to today's presenter, who is our psychiatric consultant, Dr. Hector Colón-Rivera. He's a quadruple board certified psychiatrist specializing in adult, adolescent addiction, and community psychiatry. So we're really excited to hear from you on this topic, Dr. Hector, and I will let you take over.
And thank you. So morning. I know you guys are coming from different states, different weather. Here it's pretty cold. I'm actually in Philadelphia today, and I'm Dr. Hector. So I work for a nonprofit organization, Asociación Puertorriqueños en Marcha, and we have different departments, and we cannot touch on every social determinant of health, including housing, mental health, or health in general. We also have schools and foster homes. We do help with financial and economic improvement of the community. So we're pretty proud of our programs and departments. And the topic of today is something that I love to talk about. I mean, it's pretty personal, but also professional interest. And it's something that we all, go through in any way or other. I have 3 objectives for today. Hopefully we can learn and you guys can take a few points home and about especially analyzing how the grief impact mental health. I mentioned Hispanic and Latino communities, but this can be used and implemented in any type of community, or migrants or refugees. Also, identifying the cultural and systemic challenges for our migrants and refugees populations. Also, highlighting the opportunities for cultural and responsive strategies to support the healing and resilience in these communities. My major experience and I have most experience working with Hispanic communities, also with Arabic communities and Asian communities here in Philadelphia. Probably, I would say 90% of our patients are from Hispanic or Black communities. So a little bit of mental health prevalence. We know in 2024, this was last year, an estimated 123 million. So that's a lot of people were displaced worldwide. So there's a lot of internal displacement. So you don't have to go out of your country to feel displaced. For example, I'm from a really small island in Puerto Rico. I'm from Vieques, Puerto Rico. And if you know, this is a pretty awesome, great island, but it's separated from the main island. So we suffer a lot from lack of resources. There's no psychiatrists on the island. So that displacement is pretty internally because the resources for that town, which is part of Puerto Rico, the main island, doesn't receive the same resources or help from the other towns. In terms of the population, almost 40 million were refugees, about 10 million were asylum seekers, and 6 million other in need of international protection for any reason, right? Most of them, about 71%, are low or middle income countries. However, I've seen, people come into the U.S. from also rich countries looking for protection for different reasons, political or because they're part of the LGBT community or war and the displacement. So any reason that, is pretty stressful situation for these individuals. And in terms of mental health in these communities, we know that refugees and migrants are exposed to adversity, and they are higher risk of this comorbidities, right? They include depression, anxiety, or PTSD is a huge one. Okay, but it doesn't mean that when you have a trauma itself, you have PTSD. So I want to make that clear. PTSD is a diagnosis, but most people that go through this process, even before the migration, during the migration and refugees, and post-migration status, I mean, they can suffer from different traumatic events in either or all of these phases. Many face significant barriers for mental health care. And of course, I mean, there's a lot of evidence-based strategies and intervention that can be used to enhance patient resilience, integration, and overall well-being, not only like mental health, but also physical health, which of course they walk together. So what's grief, right? Versus prolonged grief disorder. And we talk about grieving all the time. I mean, we grieve about losses, and losses are defined different ways. I mean, it could be economic, it could be the loss of a loved one, right? A political loss due to now, having someone dead is not in favor of your beliefs or the goods, right, that you want for your country. So what we know about grief and prolonged grief disorder, I mean, it does affect 10% of the individuals and have different symptoms. It could be emotional numbness. It could be as risk as having more thoughts of harming yourself, and a lot of in between symptoms like anxiety, depression, not sleeping, not eating, a lot of low concentration or attention, and most of these people are not functional. I mean, they stay home, they miss days in school, they miss days at work, so it does affect your health both mentally and also physically. And bereavement is referred to the death of a loved one. I mean, there's a lot of internal psychological processes and adaptation when someone die, right? But it's more a broadest term than the grief itself. Also encompass any external circumstances such as the alteration of relationships and living arrangements when you lost someone, right? So it's not only the grief that you have been for that person that you lost, but also what's going on around you. So more general, you're seeing the picture in more general when you were talking about bereavement. And it's just the entire experience of a family member or friends. It could be in anticipation of the death, after the death, or the consequences that happen after someone die and living following the death of a loved one. Because a lot changed when someone died, especially if that's the head of the family dying, like a mother, a grandmother, especially for Hispanic, right? Grandma is a really, really central structure for our families. So grief. So it's a natural response to loss, okay? When we talk about what's natural, what's normal versus what is not normal anymore or complicated, grief it could be following the death of someone or anything, right? Any loss you can grieve, the loss of a job, the loss of a friend, the loss of economic status. I mean, so all that we can grieve from. Um, Also, it's universal, which is really important, right? I'm mentioning Hispanic communities and other communities I'm most familiar with because that's the communities I treat directly. But it's a universal uh, uh, emotion that we suffer. Also, the duration and expression varies a lot among individuals, even within individuals of the same family. Um, so grandma died. I mean, you can have different expressions from your mother or your father or even the kids, right? You have three kids, right? The three kids can have different emotions and can suffer the grieving process in different ways and at different times. Um, and that's really interesting, and we'll talk more about that. And most people gradually adapt to the bereavement and the changes that might have without the long-term health consequences. But then when that happen and 6 months have passed, it can involve a complex process that can affect your cognition, emotional, and social adjustments. So the acute phase, we talk about the numbness, the shock, the denial, which is pretty big. I have a few patients that have lost kids, right? And that's the strongest reaction I'm seeing in my practice is when you lost a kid. And that's it's you see it different flavors, different ways and present in different ways. But that shock, that denial is huge on the first days of the death. There's sadness, of course. There's this feeling of emptiness, especially if the kid was a lot younger. Uh, there's also this which I see pretty often is, I mean, the attachment is still there, but it's broken at the same time. And there's this phase of guilty, like feeling guilty for what happened to that child, even if you were not around when the kid died, or any relationship with the cause of death. Uh, and there's the fear, the anxiety, the loneliness that you feel. And this is only the acute grief, right? I mean, there's something called the integrated grief, which is a later phase where grief becomes part of the ongoing life. And this is where it becomes a little bit complex. So the emotional pain soften a little bit. I mean, there's some capacity to joy, but you're starting to be part of, bringing the grief to be part of your living situation. So you're able to talk about it, you're able to bring it to a relationship, to activities. When this is broken, when they integrate grief, when you're unable to integrate the grief of the loss that you had, is when we have a complicated or complex grief disorder, and that has to be treated and, of course, referred to a professional if in the cases of something really bad or chronic going on. Um, but we're going to talk more about this integrated grief because I think this is really important, and people, I mean, getting misunderstand, and there's a lot of missed opportunity to treatment, also to celebrate this phase of integrated grief, that we are able to be functional in society, and we was still thinking about the loved ones and what they meant to us, or mean to us. There's a bunch of theories of bereavement grief, and I think they're really important. I mean, I just mentioned a few here so you get familiar. You can read more about them, and they will help you if you have patience or yourself to go through the process. I mean, there's, of course, a broken attachment bonds, which is a traditional view when someone is lost or someone is gone. I mean, there's a attachment that's been broke there, and it's breaking. So how do we work with that attachment? There's a healthy adjustment, which is, letting go of emotion ties to the person that died. There's a focus on moving on and forming new attachment when we go into this breaking attachment bonds. Some of the risk is may overlap cultural and personal needs to keep the connection alive. I mean, like, for example, when we're breaking the attachment bond, is we have still belongings of this person that passed, or a pretty common phase is when the loved one died and used to live with you. You don't want to go into that room, right, and pick up the belongings. Some people go in a pretty interesting phase when they start giving everything away without thinking, or as a reaction to the grief. So there are a lot of different examples, but um, that breaking attachment bond is one of the theories. Okay, the second theory is in maintaining the bond. Okay, which is a more contemporary view of the grief part and bereavement, which is a healthy adjustment that allows ongoing symbiotic, right? It's a symbiotic connection with the deceased, but we're integrating the loss. So it's more healthy way of, working with attachment. Uh, and some people, maybe you're familiar with this. For example, when my grandma died, we still have the ashes of her, and we created this mini temple at home, pictures and stuff, and we still have that corner, right, to celebrate her and her life. So that's just an example how we integrated and maintaining the bond with that person that's not here anymore. So that's a pretty cultural Hispanic way of doing things. I'm pretty sure the other culture do the same. So that's sustaining the bond. So two theories: breaking the attachment bond and maintaining the bond. So you either let it go completely or you maintain some kind of bond. Both are pretty healthy if you do it well and the family is agreeable to do that. In terms of attachment theory, and this is key to understand losses. Of course, we all hopefully related to Bowlby and Ainsworth work in the past, where they describe how early relationships are especially primary to the development of a good attachment. For example, children form an attachment with their with that person that's taking care of them and create what they call internal working model. And the self is I'm worth of love, right? So that's very important for kids. I'm worth of love. I mean, it's not like they say that, but in their uh, little brains or plasticity of the brain that's going on, they know that if they ask for a hug, they will get a hug. So this is a really, really healthy attachment. Um, but the opposite can happen, right? They can ask themselves, can I trust people, right? And that's the opposite of how the influence of adult relationship can affect them through their life, right? If they feel they cannot trust, they will have fear approaching others. Uh, so attachment theories, we have the secure attachment avoidance. The secure attachment generally facilitate adaptive grieving. We see that, right? When we trust people, loss is painful, yes, but tend to move toward this integrated grief that we talked before, that we get integrating the loss. And that's what I always recommend to my patients that are migrants or refugees, that they need to integrate the grief of being a migrant in the US, right? It's not leaving your traditions, it's being part of your life in the US. Of course, there's some other ways of going around this, but it's creating that support system. The part that's avoidant is the suppression of these emotional expressions, right? Being here without being yourself. I mean, that's pretty dangerous sometimes, and it risks to unresolved grief, and then can emerge in a different form, like depression or having somatic symptoms. Um, And the making or meaning reconstruction of the grief is the process for organizing life events, especially losses, as part of your life, like in a coherent narrative that helps that patient or helps that community to move on. I mean, it's not about getting over. I mean, it's not getting over of the grief, but it's more about finding a meaning and continuity in life after loss. And we're going back to that integrated grief process. Um, so this is another way when you talk about migration and refugee, and that process is looking for that identity of the patient that migrate and reconstruct the new reality for them. So understanding how the loss can reshape one's self-concept of being in a different um, country with a different laws and different language. Also, the purpose of renewal, right? This is a new lifestyle, a new life for you, and the process is ideal, should be like this in terms of how you integrate it to your life. So we find new ways to engage with life and honor the loss. I mean, for migrants and refugees, not only losing their countries, they're leaving, an entire life behind or family behind, sometimes kids. They move by themselves and they have 4 kids at home, back home. Okay, so then the communication is limited. And you guys know, but it's a worldwide adjustment to a new life. There's another theory. I'm just mentioning theories here, so you get familiar with different theories. But the recover, I mean, the message is pretty much kind of similar. Um, so the cognitive stress theory is just stress depression. So how we interpret the loss is the way it would affect you. It's like saying that it's not the event, it's how you react to the event situation. So that's the cognitive stress theory. So there is a lot of um, encouragement to have a positive emotional activation to the loss, right? So looking for the joy, looking for the gratitude, looking for the connection, even while the grieving process is still going on. I mean, that will help to regulate the nervous system. So sometimes we can use this type of stress theory on somatic uh, uh, therapy, right? That where we can measure how people feel in that moment with the pulse, with the blood, take the pulse, the blood pressure, the heart rate, and see how they're reacting to that emotion. It's just the stress minimization and reducing rumination when we add those positive affirmations to the loss. So some of the application in grief, we can encourage brief intentional breaks. We can possibly, help the patient to have positive memories about this loss and the sadness of loss. Incorporate tradition to that part. I mean, I put some cookies here, referring to the El Día de los Muertos, religious ceremonies and humor as tool for emotional regulation. There's also the process of a dual process model, which is between two types of stressors, the loss-oriented stressor versus the restoration-oriented stressor. So the loss-oriented stressor is directly related to the death and its emotional impact, versus the restoration is more related to how we adapt to the life changes when the new roles after the loss. So when we talk about the loss-oriented coping, we confront and confront the grief-related emotion. So we can confront the reason why we feel this way. Okay, and of course, the patient needs to be ready for this, but it's another way of working with or processing the loss. In terms of cultural, those cultures that celebrate with memorial masses, so you can tell the patient or the person to go and participate on that. They don't have to talk, just being there. Also, the collective, the morning rituals would be part of a big parade that the community is having. Just be there, don't miss it. A lot of patients ask me about, should I bring my kid to the rituals? Should I bring my kid to the masses? If they don't understand, I always say yes. I mean, some kids understand, believe it or not. I mean, 5, 6 years old, they already have some kind of identity, understanding what's there, what's not there. Also death, they can understand death. So I would say bring them, as if it's not too acutely stressor for them, of course, depending on the kid. But I think having a conversation with your kid is always welcome. So there's a dual process of coping with bereavement. Oh, we talk about this. All right. Slides. Let's repeat it. Okay. And the other one, right? The second one is restoration-oriented stressors, which is how we adapt. So here we focus more on the build the life, practical tasks, new routines, new relationships. It's not like you're gonna start dating right away, right? We're talking about new relationships that are positive for you. So for example, one I use is if this person stopped going to church, maybe it's a good time to go back. If the patient stop participating in community-based activities, maybe it's good, to show your face again, slowly. I mean, just be there, bring your kids. Sometimes losses bring family together. I mean, in funerals, you see people that you have not seen before, or I mean, for migrants and refugees, an opportunity for people to travel, right, unite the family again, to have discussions about that, to talk about the process of living here, things like that. So, in terms of culturally, I've seen that working for some patients. Now they can see families because they travel to the U.S. and they celebrate using the culture, the tradition. So that makes them feel more welcome, even though they're going through a grief and bereavement process. And of course, we know a lot about the stages of grief. We always, you know, talk about this, uh, and especially the denial and anger part, which is the pretty much the most humans ones. Is the first reaction that some of us has, like denial or anger, uh, before the the bargaining and depression acceptance. This don't have to happen in one order, right? It can happen in different orders at different times, but usually we go through these stages of grief. So bargaining, depression, and acceptance, and we will love to be in acceptance right away, but sometimes it's not happening. Maybe it's not normal at times to go to acceptance right away, but uh, it does happen a lot. It's just pretty interesting when people are, going through the process of losing someone. For example, when someone has cancer or they're in hospice and they give you, I don't know, 6 months, 3 months to live, and they're living with you. I mean, there's a process that you're seeing that person, getting worse, or getting better and then getting worse. And then this is a process of, denial, anger. And you see that stages going through that process. I mean, you see the person, my patients that are suffering from this, or have mom or dad or even a kid that is sick at home, terminal sick, and they go through all these stages during that process of hospice. So it's really interesting. But of course, we see this on migrants and refugees are going through the process of adapting to a new lifestyle. Uh, um, and this is another a model of the same stages. I mean, just this belief and yearning are different, but it's pretty much the same idea. Um, and when we go into the bereavement, that's why it's really important to talk to someone, having a counselor, going back to church, or creating a new relationship, is because there's a high risk of other disorders, right? We have seen major depressive disorders coming up, or relapsing on that, PTSD, suicide ideation. I will go further than that, right? I mean, substance use disorders, even people stopping their medication and having, exacerbation of, I don't know, hypothyroidism or hyperthyroidism, or getting uh, or obesity, right, or complicated diabetes, or not taking their heart medication and having heart attacks, strokes. So a lot can happen during this process. The DSM-5 has a diagnosis for this. I mean, this is not something I'm going to read, but it's there on the slide, so you can get familiar with the actual diagnosis per DSM-5, and it's a persistent complex bereavement disorder. I know it's wrong, it's really long, but is where we have that complex syndrome that creates this disorder, right? The self-blame, the maladaptive appraisal about oneself. There is a lot of confusion of one's role in life because of this loss. There's a huge gap, emptiness. Um, this is pretty common. I mean, we see this pretty common, the complicated grief, which is high risk of someone losing someone, right? Rates are as high as 20 to 30% in case of losing a child, losing a spouse, violent, sudden traumatic death, migration process, the low social support. So a lot of causes that can create this disorder, a complicated grief. Um, Also, it's associated with symptoms that we have seen before. Of course, the disruption of daily activities, that's why it's a disorder. I mean, and also, well, we can get as bad as suicidal thinking and behaviors of suicide attempts. Um, Something curious about is, I mean, I see a lot of people with addiction disorders, but people tend to smoke a lot more during those losses process. So even people that are migrating and refugees, right? They did not smoke before or during the process, but then when they get here, their habits come back and they start smoking more and more. Um, of course, the risk factor for suicide, this is really huge, especially if you're losing someone that you love. If that someone was a spouse or a child, there's higher risk. Um, there's some social environmental factors like social isolation, lack of support network. That's why relationship are really important. If someone does not want to go outside because they say, I'm not uh, oops, I'm not a social person, right? I mean, invite them to have groups. I mean, right, it's 2025. There's groups online. There are groups that you can connect. I mean, group like grief groups that you can connect. Similarly to if they're relapse and drug use. I mean, there's a lot of NA, AA that they can participate of, and they could be online, could be in person, could be open groups, could be closed groups. So please, please, please use this technology to expand the resources that you have. They're in Spanish, they're in different languages. Here in Philadelphia, we have a lot of these groups are online in different languages. Uh, so the complicated grief, I mean, there's the perceived and maladaptive thought that we saw in the disorder. Uh, we also have the avoidance, the reduced opportunity for emotional processing and adaptation. There's a lot of disruption in the attachment system. Even though you have a good attachment system, as a child, this can be disrupted by this big loss, especially if you were not expecting the loss. And of course, these comorbidities and social cultural factors just complicate it a little bit more and maintain this complicated grief afloat. In terms of Hispanic context, there's a lot of cultural ratios that can offer support. They say in Rezar del Rosario is one that I'm familiar with, or going back to mass, going back to church, and that reinforce some of them. It could reinforce some of the maladaptive preoccupation with the loss as well. So we need to be careful when to use the ritual, when to offer them, and if the patient is ready to go back to these traditions, cultural bound resources. But your patient, that's why it's really important to talk to them and see what's comfortable and just meeting the patient where they are. Something super interesting in COVID-19. I mean, this for me was super traumatic. So I don't know for you guys, but COVID-19 was pretty traumatic. It was a time when people were isolated. I lost friends, I lost jobs, I lost a lot of stuff. So still recovering from that. And this study is about Latinx or usually I don't use that word, but Hispanic or communities that experience a lot higher rates of this prolonged grieving disorder after COVID. And it was not only the death, but also the economic, what meant for them. Some of them moved out of the country to look for jobs, for why not. Of course, there was a lot of reduced social support. Clinics were closed, schools were closed. So not a lot of the state, federal, or nonprofit help that we usually have if they were open. So people are now, kind of recovering from this, and of course, this immigration-related trauma and stress was not processed during that time. So the patient I'm seeing now, I mean, 6 years after, is because this was not really processed during that time. The time that's really key to process the loss, or key to process a trauma, which is day one, right? So I like that study, and I mean, I invite you guys to check it out too. But I mean, about the factors that created a significant barrier to grief adaptation. And this is just one example, COVID-19. But there are many, many reasons why someone would not process grief at the time they should, or is recommended. So yep, this is another story. I mean, I call it the disruption of social environment, disruption of ritual things being closed and things like that. So it's really important to offer that point of attachment for some people. So traumatic grief and PTSD, there's some similarities, are not the same. So when you're diagnosing someone, you speak, be mindful of what you're diagnosing and the criteria for that diagnosis. But they have some similarities, of course. So they share a trigger. I mean, it's the exposure to the trauma. And of course, exposure to trauma doesn't mean that you're going to have one of these. But they have a lot of overlapping symptoms, like the intrusive thoughts, the avoidance of reminders, the hyper arousal is there too, the emotional numbing. Of course, they have the guilt that we talk about, the self-blame, the preoccupation with the death, and the feeling unsafe. It doesn't mean you have PTSD. or you have this prolonged complex grief disorder. But to be familiar with both and the similarities is really important too when you're going to diagnose or treat. Uh, and of course, you have an insecure attachment style. This could create more of the feel of abandonment and hypervigilance that can be misdiagnosed with a PTSD, but it's really just an adaptation uh, disorder that should be treated in different ways with attachment styles of these patients. Um, and the situation is when you're treating something that's not the thing that we're seeing, right? I mean, it's going to be hard to get results or people getting better. So I know we're not always looking for attachment styles with the patients, but if you're doing therapy and working with grief or loss or trauma, I think this is really key and something key to understand that attachment styles react in different ways, right? And we should treat it as that. Um, we love to talk to the psychodynamic therapist here and the participants, but maybe someone has a question about that. But this is my opinion in terms of attachment styles. It's really important to understand. Um, so these are just few attachment styles. I mean, the avoid and dismissive attachment, we talk a little bit about them. I mean, they present in different ways. I mean, for example, this one, insecure attachment, they might minimize and downplay the loss. They can avoid emotional processing and social support. So it's gonna be really hard to have this insecure attachment to go and participate in cultural or participate in um, in social events, right? That can really help them to process the loss. There's a disorganized, a fearful, avoidant, that a big loss can trigger the extreme emotional dysregulation. I mean, they can present or disorganized, they can present with disorganized speech, disorganized behaviors. Uh, and this is a strong predictor to having comorbid PTSD because it's going to take time to treat this. And remember, you're just a group an acute traumatic event, or acute reaction to the event versus PTSD. I mean, there's a timeline that defines them. That reaction to the loss of the trauma lasts longer than a certain time. You might suffer from PTSD in the future. Um, there is the perception of death. And this was written by Barry and back in 2002. The perception of death is depending how the patient died, it has a lot to do with how that person or the families that are going through the process feel or react. Um, so when you have a violent loss, I mean, most of our migrants, at least the ones that are coming from Middle East, are coming here because of war or pretty intense loss that it was out of control or not in control by them. So there's a lot of perception of that as more violent, right? And this can be associated with major depressive disorder at baseline. So also the perception of lack of being ready for that day, right? Like a war that you didn't ask for, or someone bombarding your neighborhood and you were not expecting that. Of course, it's associated with more of the complicated grief at baseline. So the follow-up, the way you are in the room with that patient is different at someone with, someone that was able to prepare for the loss, like a cancer patient or someone with a terminal ill that's dying. So this is really, really important to understand. Both can have depression, both can have a complicated grief, but of course, the likelihood, the risk of having this are higher depending on the violence associated with the loss. That's what the study is expressed. So how do we do this? I mean, how we try to diagnose it, how we try to treat it. So great questions. So there's a few inventory surveys that we can use. There's inventory of complicated grief, the ICG, and the purpose is pretty easy. I mean, measure maladaptive symptoms of grief, right? I mean, there's grief, normal grief, and there's not normal grief. Of course, higher score is it tells you the greatest severity of the complicated grief. There is the prolonged grief scale, the PG-12 or PG-13. So updated to align with the ICD-11 was the PG-13 revised, but this one just asks for 12 questions about the prolongation of the grief symptoms, and I like it because it's available in a lot of languages and it's pretty easy to remember and use. There's more that includes also bereavement and grief. So there's a text that revised inventory grief. So I like this because it's about the present feeling, but also the past behaviors. And there's the grief experience questionnaire. Is just about, touch on the guilt, touch on the somatic reaction to the loss, and the search of meaning. And this one I don't use that much with the bereavement phenomenological questionnaire, BPQ. And this focus on more on experience, including spiritual and existential dimensions. I mean, that's something that the existential part, right? The meaning of life, what happened after the loss is big to treat in therapy. So other ones are that you can add, of course, the PHQ-9s, the GAD, I mean, the Beck Depression Inventory, or depression screening that you can differentiate grief from a clinical depression, which is very important in terms of treatment. The PTSD that we talk about, right? We can measure the checklist with the PCL-5. And of course, the anxiety and depression scale. And this is if the patient is inpatient, but it's a brief tool, pretty brief, that you can use to identify anxiety or depression. So those are important. Also, in terms of treatment, always think about, at least I do, I think about CBT or prolonged exposure therapy. There are other options. There's the complicated grief therapy with evidence-based. It's an evidence-based manualized treatment, which I like. I mean, it's easy to follow, and combine exposure-based techniques and also restoration focus on work, right? Goal setting, how to get back to your normal life, or at least as close as it was, or a new lifestyle. Usually 16 to 20 weeks, can be shorter than that, depending on how much time you have with that patient. And of course, CBT. CBT we have it in all flavors and sizes. So CBT for grief is available. And of course, it's related to the problem-solving life change of the loss. It's pretty useful. I mean, I also use seeking safety as well if the patient has some use of substance use, and of course the loss, the PTSD symptomatology. You also have to mention to be omitting criteria for PTSD, but of course the basic concepts are pretty much the same. Group therapy, especially for kids, adolescents, I use a lot of the group therapy, the play therapy, especially when you are isolating and the patient is able to assist. Please invite them to a group that they can understand. If the patient doesn't speak English, don't send it to an English group. It will be really confusing. But try your best to match the patient with their either language and how comfortable they are around people that they do not understand because of the language. I've seen this multiple times. Yes, I went to groups. They didn't work for me. When I asked, it's like, where do you go? I was like, well, they don't have groups in your language. So how you did that? So that created a lot of confusion. And of course, a lot of missed opportunity, right? Because they did go to the groups, they went to the IOP, they went to the PHP programs, but of course they didn't work. They didn't grab the concept. Okay, so that's key. And then of course the self-care and cultural ritual for those that are a little bit more stable and they can take care of themselves. So if someone can participate of community meetings or the family is able to, be there for them, that's great, but always promote physical health, sleep, nutrition, eating well, activity, getting out, fresh air, and encourage them to go as much as they can to groups they can or participate in masses or the rituals and keep the tradition, right? People that keep the tradition, migrants and refugees that keep the tradition when they move to a different country do better, okay? And their kids do better. So a little bit about Maria. So 48 years old Puerto Rican woman. I mean, she's been in Philadelphia for 15 years, so that's a lot of time. She's married, she works, she's bilingual, she's of course in both with church. She presented 10 months after sudden death of a 21 years old son in a car accident. Of course, she's now suffering for persistent inability to accept the loss of the kid. I mean, losing a son at 21 is tough. I mean, I cannot even imagine that loss. I never say I understand because I do not understand what you're going through. I mean, I have a child, I have a son, and trust me, I would never say I understand what you're going through because I have not been there and I don't want to be there. So be careful with those comments. But I mean, in this case, I mean, she's pretty preoccupied with the loss. So if we're talking about attachment style, I mean, she has the attachment of being preoccupied and being anxious about this. So it's an anxious attachment style. There's a lot of strong family bonds. Of course, she goes to church, so there's some faith there that we can use. 15 years, of course, is a long time in in Philadelphia, right? And something they ask me when I talk about this case, oh, but Puerto Rico is part of America. Yeah, but I mean, the culture is so different. We speak a different language. We eat differently. I mean, the weather is different. Everything's different. So coming to America from Puerto Rico is a migration process, especially if you move for the reasons like hurricanes, um, and drug use, or someone wants you dead because of gangs and stuff like that. I mean, it's pretty much the same situation for migrants. The only difference, we have American passport. Um, but for her, I mean, she's at least bilingual, right? She's part of the community, and she's married, so a lot of protective factors there. But of course, disruptive rituals because she moved here. She was part of the COVID-19, 5, 6 years of isolation, and this death was sudden. Loss of a child, persistent anxiety, and of course the social isolation up to 10 months after the death. So a lot of protective factors, but also a lot of risk factors. So what we can use for her, I mean, this case, and this is the husband, this is not Maria. So we can use the PG-13, we can use of course the PTSD, just make sure it's been 10 months, more than 6 months, we can start talking about possible PTSD. And of course there's the depression, right? She's not eating, she's isolating, she's not sleeping well. So I think with this, we have a pretty good understanding, is this prolonged grief or PTSD or something else. Um, so so in terms of diagnosis and formulation, uh, so she met the criteria for a prolonged grief disorder, also PTSD, and of course, probably a mild to moderate depression. We identified the formulation as attachment theory. We're talking about psychodynamic or therapy. So difficult accepting separation. She's stuck, and so this is a dual process model that we talk about in a few slides. I know it's a lot of information. You can go back, you're gonna get the PowerPoints. And in terms of the formulation, we talk about the meaning making, loss not integrated into life narrative yet. It's been 10 months, she's unable to do that yet, but we need to use that meaning making model to be able to not train her, but be able to process that with her. The cognitive stress theory also help with the minimizing positive emotion activation. Remember, if you add the positive activation, it's really helpful. I mean, the positive affirmation, it will be really helpful to adapt or integrate that loss in your life's new lifestyle. And maintaining factors like rumination, avoidance, isolation, reductive rituals are the factors that are not allowing her to move on. And I'm not talking about forgetting the loss, of course. I'm not talking about that. But we want her to be adaptive and be as integrate it to her life, be present in her life so she can process that loss. I'm not asking her to forget her son. I mean, I would never ask that. And probably that's not possible. So that's not the idea. Um, so the treatment plan with Maria was normalized grief response, of course, applying the PGD, adapt traditions back. I mean, bring stuff from Puerto Rico, start eating a little bit comfort food, and go back to church if you stop going. This diagnosis, we can use the complicated grief therapy, CBT, to adapt or create or challenge those maladaptive beliefs. We can use the model of meaning reconstruction that we talk in a few slides down. Support system, of course, and if medications are needed, prescribe probably SSRIs or SNRIs, and of course work on that sleep hygiene as well. Point for discussions with this case and the PowerPoint. I want to have some question and answer time. So safety first, identify those suicide risk factors day one. Ask yourself, how can you use cultural practice to protect that person in front of you? The tools that you can use to differentiate diagnosis. It's not about labeling someone with a diagnosis. It's about understanding what we're going through so we can select the appropriate treatment. And if you don't have a diagnosis or it's confusing or it's blurry, treat the symptoms, okay? How to adapt intervention, for that migrant or refugee. Some of these surveys or clinics, not clinics, surveys or screenings are in different languages, some of them are cultural adaptive for different cultures. So use them, use the ones that are adaptive. It's really important to understand what's going on in your community so you know what clinics you can send the patient or refer the patient as well. So those clients with limited access, I always say you need to have a list of resources in your clinic. Of if your clinic cannot or do not have that service, have a list of services around you. And some of those services are telehealth, telemedicine appropriate. So use them. Some references, of course, you're going to have the PowerPoint as a reference too. You have a QR code here that you can complete the survey. And also you can use it for if you have a technical assistant or you have a question for us that you can request that.
Perfect. Thank you, Dr. Hector. That was that was really great, insightful information. So as Dr. Hector mentioned, we are going to just take some time for any questions that you all may have. Feel free to drop them in the chat or feel free to unmute and ask your question. We would also love for you to scan the QR code that's up on the slide. And we've also dropped the link in the chat. While you're thinking about some questions, we encourage you to just complete our survey so we can gather your feedback regarding the quality and usefulness of this event. And also just to hear from you all what other topics you would like to hear from Dr. Hector as well as the RMTAC team. So I will pause for a bit and see if anybody has any questions for Dr. Hector to respond to. I do see one left. Yes.
Hi, good morning. I have a quick question. Thank you, Dr. Hector, for the information. I do wanted to ask you one question. You mentioned Dia de los Muertos, and I think that was such a significant thing to bring up due to, the Hispanic and Latino culture. So I wanted to ask you regarding that. Do you feel that that particular, let's say, event or familiarity within the Latino culture brings a lot of resilience to fight this exposed, prolonged grief? If that makes sense. Do you feel like that's a cultural strength for the Latino culture? If that makes sense.
I think so. It is. If we remember the one that are not here with us, I think in terms of Hispanics, and that's what I know, at least from my family. We remember those that came before us. Not only my grandmother, but her mother and the mother of the mother, the mother of the mother, right? And we want to keep that lineage alive. So some of my patients talk to the people are not here anymore, right? So I think keeping that traditions cultures and celebrations are really important. And this is for anyone. I mean, I mentioned the Hispanic one because I do see a lot of for example, Mexican families, but it's true for anything. I mean, there's studies saying that if you keep your tradition, you keep celebrating your culture. I mean, there's the chances of you using drugs or depression when you migrate to a different country is a lot lower. So yeah, I would say it's a protective factor.
Thank you. I appreciate that.
Yeah.
I just speak for
Do you think it's a protective factor?
No, the reason I bring it up is I don't know if you can see my Catrina right in back of me. I really believe in Dia de los Muertos, and I think that's such a cultural background for my family and the people that I serve. But right now we're working with migrant children. I work with unaccompanied children, and we do see a lot of this prolonged grief, right? We don't have a lot of the exposure, and so we try not to bring up a lot of faith components or religious components, right? Because we want to be what's the word here, respectful of their cultures unless they bring it up. But I wanted to see your opinion on it, like in terms of it is such a protective factor that it will be a benefit to bring up these conversations.
Yeah, and you're right. So, for example, in my office, I don't have any crosses. I don't have anything that express any belief coming from me or the clinic. But there's a lot of ways that you can get that information from the patient or families, right? I mean, a simple question that I always ask is like, what do you do? What do you believe in, right? Or what holidays you celebrate? This is a pretty open question that they can give me a few examples. And with examples they gave me, I mean, I can understand where they're coming from, right? If I see a lot of like Muslims patient from Muslim culture, or they follow the Muslim and of course, they're different belief and they don't celebrate different holidays, or they celebrate all the holidays that we don't celebrate. I say we, I mean, I'm Catholic, but that open up, right? And the topic of celebrations or what you believe in, and you can use that in your formulation, and they can tell you information. I would not add information to that. I would just just gather that information with the answer they're giving me.
Thank you, Dr. Hector. We do have one more question in the chat.
Yeah, I have a question here from Raquel. Is that the one you're referring to?
Yes.
Yeah. So how do you get Hispanics to therapy when in some places still a taboo? Yeah, that's a great question. And there's a taboo anywhere. I mean, not only Hispanics. I do see a lot of athletes, like people that play sports, and it's a huge taboo to go to therapy. I mean, even saying therapy or therapist is a taboo. So I try to coaching, right? So changing the view of that, or counseling, or a meeting, or a get together. I mean, just try to use whatever motivation you can use to meet that person where they are. I mean, of course, there's a lot of machismo and cultural component to that, but that's why we work together with, for example, barbers, right, or the churches or community leaders that can let us know what's hot and where people are gathering in 2025, so we can get to them. Some of the clinics have mobile therapy, so they can go to group homes and things like that. You can also just offer talking to someone instead of saying therapy. I think that just the word that you use is really is a taboo. It's not even the process, it's just the word itself, like mental health, mental illness, therapy, I mean, medications, right? So there's a lot of taboo. I will give you something that helps you instead of I will give you a medication. So that's, I mean, you learn this with time and seeing people from different places, but that's the way I will offer it.
Wonderful. Thank you so much, Dr. Hector. You all may still have some other questions that are coming up for you or that come up for you later after this presentation. Please feel free to reach out to us. You're welcome to submit a CTA, what we call a CTA request, which is a consultation and technical assistance request through our website. And we can connect you with Dr. Hector to respond to any additional questions that you may have, as well as our team of clinical consultants can do so as well. Dr. Hector, you're welcome to move to the next slide, and I can show you all how simple it is. If you go to our website, you'll see right up at the top, there's a little bar that says request consultation or technical assistance. All you need to do is click that and it'll take you right to the page where you can drop your information and a question, and our team will get back to you within 1 to 3 business days. So we really appreciate you all for joining us today. Dr. Hector, thank you so much. That was really wonderful and insightful information. And we hope to see you all in upcoming webinars that we host. And like we said, please, you're welcome to reach out to us for any additional support you may need, whether it's individually or if your team would like this presentation or something similar for a coaching session.